We are now live. Hello, welcome to the NephJC Twitter Journal Club. We discuss the latest developments in nephrology in an open public forum. Everyone is welcome. We've had excellent input in the past from attendings, professors, med students, and patients. Before I go any further, I want to remind anyone watching this to sign up for our once weekly email newsletter. We use it to announce these Twitter chats, the Hangouts, and we really appreciate anybody that's participating to sign up. You can do that at our website, nephjc.com. Speaking of the Twitter chat, we meet every other week to open the discussion on a new topic and then conclude that discussion a week later with a Google Hangout where we kind of summarize the discussion. If we're lucky, dig a little deeper. This week we are looking at the recently released study, the POSEIDON trial on contrast nephropathy. And joining me today we have the lead author, Samjot Brar. Hello, Dr. Brar. Welcome to NephJC.
Thank you for having me. I'm excited to be here with you.
Great. We like to always establish whether there's any conflicts of interest. I don't have any conflicts of interest with contrast nephropathy at all. Dr. Brar, can you talk a little bit about how the study was funded?
The funding was provided by our organization, Kaiser Permanente, which is a not-for-profit. And so they were kind enough to sponsor the trial, but otherwise they weren't really involved in any other aspects of the trial, from design to presentation to publication. They didn't really have any jurisdiction over review of the manuscript or any aspect of the trial whatsoever.
So kind of an ideal situation.
Yes, especially for a topic that is difficult to get funding for otherwise.
Excellent. And in other projects that you've done, any conflicts there?
I serve as the site principal investigator for a contrast nephropathy trial that's sponsored by Osprey Medical, but that's just as a site principal investigator. I don't really get any reimbursement or any financial support from them.
Excellent. Very good. So what I want to do is I want to get everybody quickly up to speed on the trial before we kind of do a deep dive on this. So I'm just going to kind of summarize kind of a quick abstract that I created about the POSEIDON trial. Contrast nephropathy is a significant cause of AKI, causing up to about 10% of hospital-acquired AKI in some series. Standard of care to prevent contrast nephropathy essentially is sodium loading. This can be done orally or IV. You can adjust the anion. You can use bicarb. You can use chloride. You can change the concentrations. You can use normal saline and half normal saline. And that's kind of the state of the landscape, and not a lot of these choices have been thoroughly vetted. The authors claim that this trial, the POSEIDON trial, was the first to investigate various rates of infusion in a randomized controlled trial to determine their relative efficacy. They had about 400 patients, and they all received 0.9 normal saline at 3 ml per kg for 1 hour. And then the control group received 1.5 cc's per kg for the next, I believe, up to 6 hours. And the experimental group had their left ventricular end-diastolic pressure measured during their cardiac cath, and subsequent fluid was based on that measurement. So if the LVEDP was low, less than 13 millimeters of mercury, they received 5 cc's per kg per hour. If it was a medium level, 13 to 18, it was 3 ml per kg per hour. And if it was high, greater than 18 millimeters of mercury, they received what the control group received, which was 1.5 cc's per kilogram per hour. They measured the LVEDP in the entire cohort, and it was less than 13. And subsequently, the experimental group received nearly twice as much normal saline as the control group. The results of this intervention were impressive. From the discussion, they said, as compared with standard treatment, resulted in a significant 68% relative reduction in the primary endpoint of contrast-induced AKI, and a significant 59% relative reduction in major adverse clinical events. Dr. Brar, is this a fair summary of the paper?
Yeah, I think that's a concise and fair summary of the paper.
And so, you know, what was that moment when you finally unblinded the patients? And well, I guess you were blinded to the study, but you know, kind of walk us through. When did you kind of realize that you were onto something?
Only after much of the analyses were finally complete, yeah, I mean it was pretty much there at the very end after the last patients were enrolled and followed, and the data were locked and completed, and finally the analyses were done. So it took quite some time to know what the primary results was, which was somewhat frustrating. But you know, we're happy with how the results came out.
And I think for a lot of these studies, if you're not deep into the science of contrast nephropathy, one thing that's kind of difficult to look at a glance is get a sense, like, you know, how did your control group do compared to kind of an expected cohort with this risk factor? Did these people do particularly bad, particularly good? What's your thought on just the control group there?
So that's a really important point. I mean, because the control group, you really wanted to perform similar to what you would expect for patients with, you know, that risk profile for contrast nephropathy. If they end up with a higher event rate than you would expect, that would make the treatment look better. If they have a much lower rate of contrast nephropathy, that makes it difficult to understand if the treatment is effective. And so understanding what happens with the control group, I think, is really critical to understanding the results of any trial, in particular, you know, contrast nephropathy trials. The nice thing about this body of literature is we have metrics. In other words, there are multiple other trials that we can go to that we can compare to see how the control group in this study compares with others. And when we developed the trial, we anticipated a certain event rate in the control group, and we were off by a little bit, but not too bad, considering that, you know, the sample size estimations are always kind of just that, estimations. But we based these estimations off of contrast nephropathy risk scores and prior clinical trials that used very similar inclusion criteria. And so, using that background, the event rate that we observed in the control group was very similar to what we would expect.
Okay, excellent, excellent. So during the tweet chat, the people had some pretty strong feelings. I don't know if you had taken a look at what was discussed during that, but I think the general conclusion from people reading the paper was they thought that the evidence was compelling, that more saline resulted in less contrast nephropathy, but people were less convinced about the efficacy of measuring the left ventricular end-diastolic pressure. That it was not clear from the data that was provided that that was an important part of the secret sauce. Would you have gotten the same results if everybody had gotten the higher dose and you didn't vary it based on that LVEDP?
So I think the fundamental thing to understand here is this is a trial about fluid administration and hydration, and we need to kind of put into perspective what the purpose of the LVEDP is. The LVEDP was used not to necessarily reduce the rates of contrast nephropathy, but really to identify people who are going to be tolerating these higher hydration rates. And we use the LVEDP in that context to really essentially screen across the patients to identify those people who are really good candidates for the highest rates. The rates we administered, we've never really administered in a clinical trial before, certainly not for a sustained infusion period of starting pre-procedure, through the procedure, and up to 4 hours post-procedure. So for example, someone could get 500 milliliters per hour, and this could continue for the procedure, which is about an hour, sometimes 2, and maybe for another 4 hours post-procedure. And in the cardiac patients, those are not really volumes that we're accustomed to using in the cath lab. So certainly giving more volume is beneficial, and I think that's really the underlying premise of this. The purpose of the LVEDP is let's see if we can identify whom, if they get these higher rates, is going to go into pulmonary edema, and avoid that from the outset. And if we can avoid that, we might be able to establish a happy medium here. So the purpose of the LVEDP was really just a safety assessment to identify people whom, if they did get these higher rates, would have a high propensity of developing pulmonary edema. The LVEDP itself correlates very well with development of pulmonary edema. If you take a patient with heart failure, you put a catheter into the left ventricle, the LV-EDP is going to be elevated. You can't develop pulmonary vascular congestion and edema if it's related to a cardiac etiology without the LV-EDP being elevated. And so if you have someone with an elevated LV-EDP, they may not be good candidates for this therapy, or if they're candidates for hydration, perhaps the hydration has to be at a more modest rate. And the modest rate in this trial was, again, I think higher than what generally has been used in standard of care.
Yeah, so that's interesting because you did have, I think you had 6 people, 3 people in each group that developed pulmonary edema. And I don't remember if you guys reported it. Were they patients that had high LVEDPs? Was that predictive in your case?
So I think the key point there that you mentioned was that the rate of pulmonary edema with these very high rates was no different compared to control. And so you can safely administer fluids at these very high rates without causing more pulmonary edema than you would in the standard patients. The LV-EDP value itself is not a perfect predictor of who's going to develop pulmonary edema because some patients will have elevated LV-EDPs and be at high risk. Some patients may, however, have normal LV-EDPs, but they may not have normal ventricular compliance, and their LV-EDP may increase at a very rapid rate with hydration. And so in some patients, you can find patients at baseline have a normal LV-EDP, but because their ventricle is not very compliant, maybe from long-standing hypertension or some other cardiovascular process, that their LV-EDP rapidly increases and they do develop pulmonary vascular congestion. So we saw a mixture of patients with elevated LV-EDPs and some with normal LV-EDPs in those 6 patients, 3 in each group that required termination of fluids. Now, it would have been really interesting to be able to reassess the LV-EDP to see if the patients were complaining of shortness of breath, whether that really correlated with, developing pulmonary vascular congestion, and prove that with the LV-EDP. But therein lies one of the challenges of using the LV-EDP, is it really is not a metric that you can go back in and reassess just for the academics.
Excellent, excellent. So one of the other things is that you measured LV-EDP in your whole cohort, and so some people were also interested in knowing, was it an independent risk factor for contrast nephropathy, especially in the control group where you had these measurements? Did people with low LV-EDPs, essentially a tank that's empty, have a higher risk as one might expect?
No, it doesn't work that way. The LV-EDP doesn't really, your tank can't get that low. Where your LV-EDP would become that low that you would be at risk of contrast nephropathy. We explored this relationship in a prior trial, the MENA trial that was published in JAMA in 2007 or 2008, and that was a comparison of 2 different therapies, bicarbon saline, but in the process, LV-EDP was measured in all the patients because they were coming through the cath lab, and we routinely do this, and so we actually looked at that relationship to see if these really low values would potentially predict contrast nephropathy. And there isn't really a reliable relationship there. The other thing you have to remember is patients with lower LV-EDP values or normal LV-EDP values tend to also have less cardiovascular comorbidities compared to patients with higher LV-EDP values. And so there's another confounding factor between the LV-EDP value and the risk of developing contrast nephropathy. And so we really look at this metric as really just a safety assessment to identify patients who are going to be good candidates for tolerating the fluid, not necessarily as a method for predicting who or who will not develop contrast nephropathy. I think there's a distinction there that's confusing.
Outstanding answer. Thank you. That really put some light onto that. One thing that I didn't see anybody comment about when I was thinking about this trial is this trial was not so much about prophylaxis, because the change in treatment really happened concurrent with the administration of the toxin. But this is almost like a trial of an antidote. Is this really the first time we've seen an intervention for contrast nephropathy where the intervention was concurrent with the administration of the contrast? It seems like every other one we've seen, they have to have some lead time. I thought that was unique about your trial. Was I off base there?
No, I think that's a fair characterization, and that's very different from other pharmacologic strategies that we've tested before, like N-acetylcysteine is the typical one where it's administered up front, or at least started up front with the hopes of mitigating risk of injury. But the hydration strategy used here has been, let me step back, the duration of hydration used here has been studied actually many times. There's probably close to 20 trials that now use this abbreviated hydration protocol where fluids are started not too long before the start of the cardiac procedure and then continued for a finite amount of time thereafter. But in some ways it is you can characterize it as an antidote, but it does fit within the context of a body of literature that where many trials have studied these more abbreviated protocols. There are a lot of logistical issues and problems with hydrating 12 hours before or 12 hours afterwards, or for a total period of 24, 36 hours. That's something that you can do in the hospital, but many patients get contrast exposure on an ambulatory basis and really doesn't help them.
Excellent. One of the things that delighted me about this study was you guys had really expansive secondary outcomes, which I think to a large extent are very important. Clearly, your primary outcome was a bump in the serum creatinine, like we've seen in all the contrast nephropathy studies. But you really addressed one of the hot issues in AKI, which is how much of this acute renal failure is persistent, how much of this leads to chronic kidney disease. And you guys found a significant difference of persistent persistent AKI, at least is what you labeled in your study. Can you give a little color on that?
Yeah, long-term follow-ups are generally missing in contrast nephropathy trials, which has been problematic because there's been some controversy about whether these changes really correlate in the long term with important clinical events. Along that line, one of the things we were interested in to understand is for people who do develop AKI, what percentage might it be persistent? Our version of persistence was on a slightly shorter time frame than what most nephrologists would probably define as persistent, there's some shortcomings with that, but it was a secondary aim of the project to begin with. But we found that amongst the patients who develop contrast nephropathy, 50% really don't significantly recover renal function, which is a very sizable percentage.
Yeah, so just to elaborate for the viewers, so their definition of persistence was 2 weeks, or at least the lower end was 2 weeks, and it kind of extended out from there. But you did come back and you did follow a significant, was it a serious coronary adverse events, and you had those extending out at 6 months, really significant negative outcomes to these patients. One of the things that I noticed, you have a plot showing events over time, and there were a lot of increase. I think it was MIs greater than 90 days out past cath. There was another bloop to that table. You know the table I'm speaking of, the graph I'm speaking of.
Yeah, the Kaplan-Meier figure.
Yeah. So the question that I have is, what's the mechanism? 90 days after a cath, you see this a bunch of secondary events happening in this cohort of patients that were in the control group, and it seemed to stretch credibility to me.
So this is, I think, a complex issue, and we're not really the first to observe this or report this. Maybe one of the first or one of the earliest reports in the context of a clinical trial. But there are some observational studies that have identified this association or this relationship previously. Patients who develop contrast nephropathy have higher rates of long-term outcomes, including in particular myocardial infarction. There is some interrelationship there between that deterioration of renal function and progression of cardiovascular disease, how that promotes progression or instability of plaque and leads to events. I don't really think we have a good understanding of that, but this data largely supports what's been reported in some of these small number of observational studies looking at these longer-term outcomes. And I think understanding these longer-term outcomes is really critical to being able to understand, the importance of contrast nephropathy and the value of these upfront therapies for preventing it.
Yeah, I think it was interesting that your article came out within a week or two of the coronary trial, which really went the other way with this, showing no difference in long-term, at least CKD outcomes, based on a defined difference in the AKI. It kind of feels like the page has been turned, and we still have conflicting data on this issue. Any thoughts on that coronary trial?
No, I haven't seen it in detail yet, and so I don't really want to.
No problem. Don't worry. Just blow through that then. Let's not talk about what you don't know. Let's talk about what you do. Yeah. So I guess what I would say is where you I think there was a couple of mentions in the trial that this was kind of a pilot trial, initial ideas. Where are you guys going from here? What's the future for this group for this field?
I think one of the critical things is here we need to move forward with identifying more effective hydration strategies that we can apply to a broader group of patients. I think the concept here is identify metrics that allow us to stratify patients for risk of developing pulmonary vascular congestion or edema, and then based on those metrics, identify patients who are good candidates for very aggressive hydration. I think that current standards are fluid administration. These protocols, the rates are just too low. And whether there is benefit of these low rates over longer periods versus the high rates over shorter periods, whether there is this important difference there, I think that that is a point of debate and something that may need to be addressed. At least these data suggest that hydrating very aggressively around the time of contrast exposure significantly can reduce the rates of contrast nephropathy. The event rates largely parallel, what we see using the matched diuresis system or the renal guard system that has been studied in Europe, and there the concept is you do increase the intravenous fluid rates, and in parallel you increase the urine flow rates. But it's interesting that the event rates we see here without having to place a Foley catheter and diurese the patient are largely in the same order of magnitude as you see in that system. And again, that system's been largely studied to date in patients undergoing cardiovascular procedures. And also the pulmonary edema rates are actually quite similar as well.
Excellent. So right now, I think the NIH is sponsoring the largest AKI trial ever. I think this is the normal saline versus sodium bicarbonate 2x2 factorial design with mucomist thrown in there. I know you guys looked at mucomist. You saw no effect whatsoever in the rate of contrast nephropathy when you stratified patient mucomist or no mucomist. Any thoughts? What is this? Is it the? I'm trying to think of the name of the trial. It's escaping me. The PRESERVE trial. Any thoughts on the future of PRESERVE?
Well, it's interesting that such a large trial is being funded, especially for N-acetylcysteine. In multiple trials, at least 2 that we have done, we've gone back and we've looked at patients who've received N-acetylcysteine. Now, in our trial, we don't really advocate for its use. If someone starts the therapy, then we will complete the course. And certainly as part of the protocol, we did not encourage it, and it's not something that we routinely use in our practice. We get patients referred from a large geographic area, and so physicians have a lot of different practice patterns, and those who do start it, we would continue the therapy in those patients. About 1/3 of the patients received N-acetylcysteine, and the event rates are nearly identical amongst users and non-users in the trial. We've looked at this previously in a trial where we compared sodium bicarb and normal saline, the JAMA paper that I referred to a bit earlier. And in that trial also, there was no difference between N-acetylcysteine users and non-users in terms of providing.
I'm sorry that I'm not familiar with that trial. I mean, I've read a bunch of sodium bicarb trials. I'm just not sure which one you did. Was that a positive or negative trial for bicarb?
Negative trial.
Negative trial. So, yeah. Okay.
We saw very similar event rates in, again, a very similar population to that was studied in this trial.
I will tell you, as a nephrologist, I'm much more comfortable with negative trials. We had a hard time reading your trial because it was a positive finding. It was uncharted territory for us.
I think contrast nephropathy, we have to be careful about positive trials because many times we've been led astray in terms of very spectacular results only later to find very muted or very neutral results. And so I think that's what N-acetylcysteine has had, and that's what I think PRESERVE will show about N-acetylcysteine.
Yeah, that's certainly the case. Though I'll tell you, we had 30 people at our Twitter chat going over your paper with a fine-tooth comb, and I think the consensus at the end was it was an extremely well done study. There was a couple of questions about things that weren't discussed. You've discussed all of those aspects here tonight. I want to congratulate you for an excellent paper. Really well done study. Last question that I have, a little kind of inside baseball. How do you end up in the Lancet? Where did that come from?
Yeah, I mean that's up to the journal largely in terms of making that decision, and we felt that this was really something different from what had been studied. Really, we teach our fellows and our trainees the importance of hydration, yet there are very few trials that actually compare different hydration strategies. So something that is perceived to be the cornerstone of contrast nephropathy prevention, we have these statements and guidelines, both in the cardiovascular literature and in the nephrology literature, and they're based on very, very, small amount of science and very little in the way of clinical trials, in the absence of head-to-head comparisons as well. And so we felt that this addresses a very large void, and it doesn't really answer all the questions by any means, but hopefully it changes the discussion from all of these other ancillary therapies that there's been a lot of debate about, to getting back to the basics and saying what can we do to identify and develop hydration protocols for different patient populations that are
excellent, excellent, Dr. Brock. Thank you so much for joining us. This has been a great hangout. I've really enjoyed getting all these final questions about the trial really put to rest. The last thing I want to do, I just want to announce next week's Twitter chat. Next week we're doing kind of a change in gears. We're not doing a research trial. We're not doing a clinical practice guideline. We're actually doing an editorial perspective piece by Richard Johnson and his group on the Central American CKD epidemic. This was published as the lead story in Nature Reviews Nephrology in May. And for the first time, this is really exciting, they reached out to NephJC. We'd already selected the article, and we told them that we had selected it. They said that they would make it open access. This will be limited open access. Nature Reviews Nephrology, outstanding journal, but it's all behind a paywall. But they've opened up the gates for this editorial so that everybody can read it for NephJC. And in the end, the story about this Central American CKD epidemic, you read the stories about it, it's absolutely horrifying. We don't have a firm handle on what's causing it. I think it's going to be the story of the decade in nephrology. Just a couple of days ago, bouncing around Twitter was a map of the world where every country was labeled with the leading cause of death. And there was a lot of cancer and a lot of heart disease all around the world. You go to the Far East Asia, and you saw some hepatocellular carcinoma show up, some HIV in some sub-Saharan Africa, but in Central America it was CKD and nephritis, and I never expected it to be a leading cause of death. And I think that really shows kind of the potential importance of this this new disease entity. And so we'll be talking about that next Tuesday night at 9 o'clock Central. Thanks one more time, Dr. Brar. I appreciate having you.
Thank you for having me.
Bye-bye.
Bye-bye.